Let's finish up traumatic brain injury. This is a continuation of increased ICP, which we have done previously. Traumatic brain injury, by the name it implies, this is from trauma. The trauma can be anything. It could be from sports injuries, it could be violent um, victims of violence, rather. It could be, like I said, accidents, or it could be self-inflicted, such as if you have a suicidal patient, or um, a patient who has mental illness. Now, there are a few types of head injury. Most common is a coup contra coup injury, such as this one. The force usually, unlike a penetrating trauma, this one is obviously a blunt force trauma because the skull is still intact. We have previously discussed the concept of the Monroe Doctrine, wherein we discussed the, the doctrine which states in a close head injury such as this one, if volume in one of the components, namely either the brain tissue, blood volume, or cerebrospinal fluid, increases, then volume in the another compartment must be displaced. Um, and we already talked about the effects of increased intracranial pressure, which is unfortunately brain herniation. And we have also finished discussing the various ways of brain herniation. So in this part of the chapter, this will deal with, if you remember, I mentioned that there are secondary injuries that will result from the primary injury. So this is now the continuation. Fractures can be open or closed. We have finished the consequences of a close head injury or close skull fracture, which is already mentioned, pertaining to the Monroe-Kelly doctrine and the increased intracranial pressure, signs and mechanisms, signs and symptoms, and management. Table 39.11 gives you the other types of head injury. Skull fracture, as already mentioned. We have penetrating injury, which can be a bullet, a gunshot wound, or a stab wound, or any other traumatic force. Concussion is, as I mentioned previously, concussion is a form of mild head injury. Contusion, sorry, please take note of this sentence right here. Concussion, although listed under or categorized under mild head injury, however, as stated here, multiple concussions, or if it is results in a repeated episode, such as in sport of boxing, for instance, or in football, um, the the consequences can be devastating, meaning it may result in permanent brain injury over time if it is repeated. A contusion is an actual injury to the brain tissue itself. Usually, this results in a bleeding. The bleeding, of course, varies. The amount of bleeding varies. If it is large enough, then definitely that will form a hematoma. And you have several types of hematoma here, which we have established in a previous lecture, that any hematoma, regardless of which layer of the head this is located, either above or underneath the dura, for instance, or between, this these things are still space occupying lesions which can increase ICP. DAI, or diffuse axonal injury, as opposed to a focal injury. A focal injury is just like here, for instance, if you have a coup injury, so the injury is um, focused on one area or two areas, such as this one. Okay, so that's hence the name a focal injury. A diffuse axonal injury is different because there is no specific area that is injured, but rather diffuse, meaning the injury involves a large area of the brain, and there may or may not be any um, bleeding. Okay, but there is still neuronal injury, meaning there is injury to the brain, but the injury is much deeper. And as stated here, they typically don't show on um, a CAT scan or an MRI here before 24 hours. So usually the evidence will occur later, at which time the patient's injury has already um, become more serious. Please read on your own here about the signs. Like here, for instance, we have signs of a basal skull fracture, like this one, the raccoon eyes, or this one, a battle sign. Okay. The important thing here is please review how do you identify whether or not there is a CSF leak, because we do have a skull fracture. So the CSF leak can be through the nose or even out of the ears. And of course, how you do that is using the halo sign. So please review on how to detect or test for the halo sign. We already discussed these in the table, so please read the details. I may get questions from the paragraph in addition to what's on the table. Here is the neuronal injury, which is usually existing together with the diffuse axonal injury. Vascular injury, these are of course hemorrhages, and we already discussed about hematomas that can form, which all lead to increased ICP. Management. Now the management is not any different from the section under increased ICP. Signs and symptoms of management are identical. Diagnosis, this again is not any different from increased ICP. This is your main problem in head injury, is to identify and manage increased ICP. So this will include what we discussed earlier with monitoring, and we already instructed you that we will only test and manage the intraventricular catheter insertion. So only that technique, okay? Because we already discussed that there are several ways to monitor ICP, but the most common is the gold standard is the intraventricular, because for reasons that that method not only measures ICP, but more importantly, it allows for CSF drainage, which can actually be part of decreasing ICP. Surgical management. This is no different from what we did again under increased ICP. That part involves craniotomy, and we also included in the previous discussion the craniectomy, and marsupialization as well. So as you can see here, nursing management, again, these are all deja vu. These are nothing different from what we did earlier in this chapter under increased ICP. If you compare the this one with the increased ICP, it's really the same thing. So you look for, I hope you still remember the concept of cerebral perfusion pressure, and formula of course is MAP minus ICP, and I trust you already know how to calculate for the patient's MAP. These patients tend to have seizures, again, a complication or a consequence of increased ICP. So just like the concept of compartment syndrome. Actions, these are all actions toward not only managing increased ICP but as well as promoting healing. Okay, so first is the positioning, of course, and we already discussed that patient must be in midline or in a neutral position. No hip or neck flexion is allowed, because those of course will increase ICP. Managing CSF leak, if any, because this is now under head injury. No procedures that can increase ICP further, especially a nasogastric tube. So for feeding here, I know this is followed by enteral nutrition. The route, of course, will not be an NG tube. These patients will receive a PEG tube instead, because they will be unconscious for quite a while, and we don't want to use parenteral nutrition because there's really nothing wrong with the patient's GI tract, so we would prefer the GI nutrition via a PEG tube. Temperature management, of course, we already discussed this intervention because hyperthermia will cause increased ICP because they cause vasodilation. So here we give antipyretics or other cooling measures. Again, the patient with increased ICP is prone to seizures, so institute seizure precautions as well as administer anti-seizure medications. These patients are intubated, unconscious, so of course complications of immobility, namely VTE formation as well as pressure ulcers. Teaching would of course be, if not for the patient, because they are unconscious, then it will be the family. And that concludes traumatic brain injury.